Hi friends, hope you guys are revising well and on track for your INI-CET exam. So we have come with a special series which is your INI-CET Surgery Extra Edge series. So today we'll be discussing in this video regarding your applied surgical anatomy of breast. Now breast is a very important topic for any competitive exam. Now moreover, with the recent addition of Bailey and Love, the breast chapter has been written by the professors from AIM. So it makes it a very important topic where you can expect at least 2 to 3 questions coming from the breast itself. So let's begin a discussion on the applied surgical anatomy of the breast. So first, regarding your breast anatomy. Now it overlies the pectoral region. So what is the extent of the breast? Above, it extends up till the second rib, then below up till the sixth rib or your inframammary crease. It is very important for us to know regarding the extent of the breast, and even MCQs can be framed from here by asking you regarding which of the following is true with respect to the extent of the breast. So it extends medially up to the lateral border of sternum, and laterally it extends up to the mid axillary or your anterior axillary line. Now what about in adult males? In adult males it is rudimentary, a size of approximately 2 centimeter. It lies deep to your areola and it extends up to your areolar margins. Right. Now this is a very basic diagram taken from your Bailey and Love regarding your cross-sectional anatomy of the breast. So you can see regarding the pectoral fascia, the premammary fascia, the suspensory ligaments of the Cooper, this is your ampulla, this is your nipple and the areolar complex, these are your lactiferous ducts, then this are your mammary lobules, this we have as your subcutaneous fat. So the extent of the breast is from your second to your sixth rib. Now moving down to the breast parenchyma. Now breast parenchyma is made up of your ductolobular tissue plus your supportive tissue. Now first, regarding your ductolobular tissue consists of your terminal ductule plus lobule, and this together is called as your terminal ductal lobular unit, also known as TDLU. Now this TDLU is very important. Why it is very important? Now this is the most active part of your breast tissue. Now this responds to your number of hormones, and the most of the diseases of the breast arise from this TDLU. Now around 50% of your ductolobular tissue is in your upper outer, whereas 20% is in your central. Now as we have discussed that this TDLU is the most active part responding to number of hormone, and the most diseases of the breast arise from the TDLU, and around 50% of ductolobular tissue is situated in your upper outer quadrant. So we get a very important MCQ over here. The max attention in your breast examination should be given in these regions, right? That is your upper outer quadrant, retroareolar and your nipple areolar complex, right? So this is your importance of terminal ductal lobular unit. Now moving down to the next part, which is your supportive tissue. So supportive tissue is your suspensory ligament of Cooper. Now this have your this has your two parts, one is the superficial and one is the deep. So superficial it is up till your under surface of dermis and deeply attached to your pectoral fascia, right. Other supportive tissue includes your adipose tissue and your blood vessels, nerve and lymphatics, right. Now coming down to the areola and nipple, so they are involuntary muscles arranged in form of concentric rings. So these are the circular muscle fibers which constitute what? Your Sappes fiber. Now these are responsible for causing erection of nipple, another important very MCQ. Then radially it are longitudinal muscles which is known as your Meyer-Hall's muscle. Now this is responsible for your retraction of nipple. So erection of nipple is because of your Sappes fibers and your retraction of nipple is because of your Meyer-Hall's muscle. So this is a very important topic and an expected MCQ from this region. Then regarding your areola and epithelium, so this consists of your sweat and your sebaceous gland. Now this enlarged during pregnancy and they serve to lubricate during lactation, right, and this is what is your Montgomery tubercles. Yes, right. So this was about your structural anatomy of the breast. Now the most important part in your anatomy of breast is with respect to your lymphatics. So the predominant drainage is into your axillary group of lymph nodes. So first let's know what are the various levels or what are the various group of axillary lymph nodes. So first we discuss regarding your lateral group. So what is your lateral group? Now lateral lies along the lower border of your axillary vein line lateral to the thoracodorsal vascular pedicle. Then we have your anterior of pectoral. Now this anterior of pectoral lies between the lateral border of pectoralis major and minor and lateral thoracic vessel. So another important point to remember is that this anterior of pectoral are your most common sentinel lymph node. So when we do the sentinel lymph node biopsy, the most common sentinel node is usually from your anterior or the pectoral group of lymph nodes. Then we discuss regarding the posterior group of lymph nodes. So these are along the subscapular and the thoracodorsal vessel just anterior to your latimus dorsi. So please remember this important definitions. Again, the questions that can be framed from here could be direct one-liners, or they might give you 4 options and ask which of the following is not correct, which of the following is correct. Then we have your central or medial. So these are embedded in the fat of center of axilla. Then we have your rotor nodes, or which are also known as your interpectoral node. So these are between your pectoralis major and minor muscles. And then we have your apical nodes, which are above and medial to your pectoralis minor tendon lateral to the first rib. So these are your various group of lymph nodes, and they are divided surgically into the 3 groups, which are level 1. So what are your level 1 group of lymph node? So these are below and lateral to the lateral border of your pectoralis minor. Level 2, they are in front and behind the pectoralis minor muscle, which also include your rotor nodes. Then we have your level 3, which is above and medial to the medial border of pectoralis minor muscles. Right. Now, why are we discussing so much in details regarding your axillary lymph node? Because is an important constituent of your modified radical mastectomy as well as your breast conservation surgery, right? The various surgical steps are not going to be discussed over here in your surgical anatomy. So let's look at the basic diagram of your level of axillary lymph node. So we have this level 1. So if you look over here at the level 1, what is level 1? Please refer back. It is below and lateral to the lateral border of your pectoralis minor. Then level 3, right, is medial to the pectoralis minor, and then we have your level 2, which is in front and behind your pectoralis minor. Now, what are your various important complications that happens during your axillary dissection? Now, tell me what happens if your long thoracic nerve is injured. Yes, it is your nerve to serratus anterior. So, nerve to serratus anterior. So, if this long thoracic nerve or the thoracic nerve of Bell is injured, you will have your bringing of scapula. So, this is one very important and the frequently asked question from your long thoracic nerve. Then another important nerve over here which has the chance of getting injured during your axillary dissection is your thoracodorsal nerve. Now, what is the supply? What is this thoracodorsal nerve supplying to? They are supplying to your latimus dorsi, right? So, there could be injury to your latimus dorsi muscle. And what are the functions of your latimus dorsi? So, the role of your latimus dorsi is to adduct, medially rotate and extend the arm at your humeral joint, glenohumeral joint. I'll just write it down again, and extend the arm at your glenohumeral joint. So, patient may have difficulties in such movement, right? And also apart from this, another nerves that are damaged are your intercostal nerves. So, what happens over here? Because of this, there would be numbness or basically loss of anesthesia at that particular area, right? So, these are your few important points with respect to your axillary lymph node. And apart from this, when we are discussing node, I would just add the nodal staging over here. So, clinically N1 is your metastasis to ipsilateral movable level 1 or level 2 axillary lymph node. N2A is your metastasis to ipsilateral fixed or matted lymph nodes. Then your N2B is your metastasis to ipsilateral internal mammary node. Please note, in absence of your axillary lymph node metastasis. Then you have your 3A, which is metastasis to your infraclavicular lymph node. Then you have your 3B, which is ipsilateral and internal mammary lymph node and your ipsilateral axillary lymph node. And then you have your N3C, which is your metastasis to supraclavicular lymph node. Right. So, this were your important points with respect to your applied surgical anatomy of the breast. So, please do remember regarding your TDLU, which is your terminal ductal lobular unit, and your axillary lymph node, the various groups, the various levels, and the various complications that could be associated during the surgery of your axillary lymph node dissection. Thank you.